Our next lecture for today's CME is by our guest speaker, Dr. Iqbal Musani sir. He is alumni of this prestigious institute and completed many modules in advanced immunology, molecular biology, dry chemistry, infection control, blood banking in different countries across the globe. At present, he is working as clinical pathologist in lab medicine of groups in Saudi Arabia. To chair this session, I would like to welcome Dr. Chaitanya Shembekar sir, Director, Omega Hospital, Consultant Obstetrician and Infertility Specialist in the city, and Dr. Sunil Ambulkar sir, Senior Endocrinologist in the city. I hand over the proceedings to chairpersons.
One word, Dr. Chaitanya Shembekar is the only chairperson for this session. And this photo is 20 years back.
So I have taken this from the Google.
And I am honorary assistant professor at that time. Now my upgradation has occurred. Now I am the professor in endocrinology at GMC and superficiality. Right? So, so let Dr. Chaitanya take over. We'll listen to sir and then I will take your permission, madam, after half an hour.
Over to you, sir. Dr. Iqbal Musani, sir.
So, I welcome Dr. Iqbal Musani for this talk on reproductive endocrinology. And coming to GMC is like ghar wapsi for me. And I am feeling so nostalgic. And special thanks to Dr. Manjushri Vaikar, Dr. Mirnisa Kamal, and Dr. J.K. Deshmukh for giving me this wonderful opportunity. Whenever a baby is born, it is a miracle called life. And it is always an orchestra which is responsible for this miracle called life. And this orchestra is actually a conductor of this orchestra or a music director is hypothalamus. So we all know that it is the hypothalamus which is a higher center. And whenever we talk about higher center, then comes the role of emotions. So emotions also play a very important role in this orchestra. And we are so fortunate to have Dr. Iqbal Musani. He is from 71 batch. Oh, great. I am from 86 batch. So, 71 batch GMC Nagpur. So happy to have you here, sir. Over to you. Thank you so much.
Honorable Professor and HOD, Dr. Kamal, Honorable Dr. Vaikar, Honorable Chairman of this evening, my dear friends, ladies and gentlemen. At the outset, let me tell you, it is a great pleasure for me to come to my alma mater, come to my medical college and deliver this lecture. And nothing can be happy in one's life when he has been asked to come in his own institution and has been called to say few words. So, without wasting the time, let me straight plunge into the subject. Hormonal evaluation of female infertility is a very well-known subject, but it is also difficult to understand and come to the conclusion. So, let us begin from the basic. Infertility is defined as a failure to conceive despite of regular unprotected sexual intercourse over a specific period of time, usually 1 to 2 years. I remember, before 10 years, almost this definition was holding good to 2 years. People were waiting for 2 years and then the investigations for the infertility is to begin. But over a span of time, in last decade, it has even fallen down to 1 year. So now the people begin the investigations of the infertility immediately as soon as even less than 1 year happens because of the circumstances in changing and situation in changing. Particularly the mother-in-laws are more interested in getting a child as early as possible from the daughter-in-law, and that is the one which provokes them to start immediately. Infertility incidence, if you look at in general, is almost 10 to 15% of the couple, and in normal young couple, the fecundity, almost 25% of them, they conceive after 1 month. So conception after 1 month is almost 25%. 70% of the couples they conceive after 6 months. So 6 months is fairly good time to be given to the couples to get conceived. 90% they conceive at the end of 1 year. So remaining 10% are the people who need to be supported in investigating for the investigations for the infertility. Now, infertility risk factors are very, very important. And of course, I know you have all the learned here crowd, so I need not go into the details. As the woman's age advances, the fecundity goes down, and other important factors are smoking. Now, on smoking, if you look at the Western world and also look at the Scandinavian world, you would find that women have taken to the smoking very, very high percentage. They have already crossed the limit of males in smoking, and this smoking is one of the most important factor in infertility. Taking illicit drugs, particularly the drugs which will lead to the habituation, they have a great role to play, and then occupational and environmental exposures. So these are the unassuming factors that needs to be taken into the consideration while we are investigating a case of infertility. Now, basically, I will just run through it, primary infertility and secondary infertility. I know you have all understanding of this one, so I will not explain. If you look at the diagram of infertility, female factors is the maximum one. Almost 50% is a female factor involved in infertility, 35% is a male factor, and 10% unexplained infertility, where we fail to explain what is the cause, and then 5% is the combination of the various factors two together, and that is responsible. The causes of infertility, as I explained to 35% factors are male factor that we are going to leave aside, and then female factors are the important responsible factors are related to ovulation, 20%, tubal and peritoneal factors are almost making 20%, and uterine and cervical factor are almost 10%. So, mainly ovulation, tubal and peritoneal factors, and uterine and cervical factors that needs to be thoroughly investigated to find out the cause of infertility. Now, unexplained infertility, which is our major problem. We cannot come to the conclusion. At the same time, we are unable to treat the patient at its own target, and that needs to be addressed very, very patiently. And at the end, you will find that 5% of the couple, in spite of doing everything, do not conceive. And I'm a firm believer of the fact that the great Lord of the universe, whomsoever he wants to give a children, he gives. And whomsoever he do not want to give the children, they all fall under the 5% of unexplained infertility. भगवान की इच्छा जब नहीं होती और वो किसी को बच्चे देना नहीं चाहता, वो नहीं देता. आप कुछ भी कर लीजिए, it will not happen. वो कैटेगरी जो है, वो unexplained कैटेगरी है. मगर, the women, they are desperate because they want to have a child, और वो कुछ भी कर सकते हैं. And under that situation, they are exploited. Then, a combined factor, they form 5%. And in combined factor, we have male and female factors, sexual disorders, and then immunological factors. We will come to it one by one. Approximately 50% of the couple will conceive after receiving an advice and simple treatment. So, just advice and simple treatment would make 50% of the factors, 50% of the problem solved. For 4% of the couple will remain involuntarily childless. These are the people who, in spite of doing everything and all efforts goes in vain, they remain as it is. Male factor is the reason for infertility. In 35% of the cases, what we have seen, female factor is identified, and then fertility reduces rapidly over the age of 35 years. So, factors affecting the fertility in women, let us try to work out one by one. Ovulation disorders, tubal damage, age above the age of 37 years, low coital frequency or inappropriate time of intercourse to the ovulation. This is one of the major important factor, and this is because of the people are interested in making their career. People are interested that they should have a very good atmosphere of working, and in that they remain apart from each other, and there is a disproportionate frequency of the coital to the time of intercourse, to the ovulation. This is one of the major factors. No previous pregnancy, smoking and malnutrition, obesity, underweight, endometriosis, fibroid, and pelvic inflammatory disease are few of the important factors that needs to be ruled out. Conception for a woman to conceive, certain things have to happen. These are all the natural things, and that needs to be basically happen, and these are the three important factors. Intercourse must take place around the time when an ovum is released from the ovary. So ovulation time and the time of intercourse has to be matched properly, and that we advise the women that between 11, 12, 13 and 14 days, she must indulge in a good number of intercourses so that she has got a chance of getting fertilization. The system that produces egg and sperm to be working at an optimum level. So this is one of the important factors, and then her hormonal status must be up to the normal level. So hormonal status, frequency of intercourse during the ovulation period, and the system that produces the ovum from the ovary has to work at a basic level. So that minimum 18 to 20 millimeter of the ovum has to be produced, at least 2 or 3 ovum, and they have to enter normally into the fimbriated end of the fallopian tube. So these are the important factor. These are the forerunners of the consolidation. This is a basic diagram where the three level, that is an hypothalamus, pituitary, and 2 ovaries in the abdomen. This is basically a diagram where they are under the control of each other's negative or positive effect. So, according to this, the WHO has classified the group 1, that is hypothalamic pituitary failure, the group 2, hypothalamic pituitary dysfunction, not failure, and the third one is ovarian failure, that is at the terminal failure of that particular end, where ovarian failure leading to hyperprolactinemic changes. So these are the 3 different groups, and these 3 groups needs to be investigated. Out of the 3 groups, the major group is group 2. Almost 80 to 90% of the cases of infertility fall in this particular group, while rest of the other groups, they are minor in terms of, and some of that groups where nothing can be done, including IVF. So these are the things where now let us talk about one by one, and let us try to negate one by one in terms. Ovulation disorders arise due to the defect in the hypothalamus, the pituitary and the ovary. All the 3, super center, middle center and the lower center, are responsible for the ovulation disorder. Now, they are classified again, as I said, into 3 groups. I will not repeat it again. Now, let us talk about the WHO type, where we decide the hypothalamic pituitary failure, that is the group 1. In hypothalamic pituitary failure, what are the criteria which are taken for granted for the diagnosis is hypogonadotrophic hypogonadism. This is hypogonadism is one of the major factor in group 1. Low level of follicle stimulating hormone, normal LH and normal estrogen, normal prolactin level. There is no hyperprolactinemia here, and presents with an amenorrhea and the progesterone challenge test that is done at 21st day is negative. So all these factors are responsible for producing what you call it the type 1 type of Now, WHO type 1 hypothalamic pituitary failure is caused by anorexia nervosa. These are the important causes of type 1. While exercise related, these are the causes, those people who are athlete, those women who are athlete, over exercising or running in marathon or any other, these are the women falling in this group. Post pill amenorrhea. Nowadays, I know the women are more career oriented, so they want to avoid the pregnancy, so continue the pills for a very long time. The effect falls on the hypothalamus because of the negative feedback mechanism. pituitary infarctions like Sheehan syndrome, Kalman syndrome, and the most important out of them is hypothyroidism, which we always forget to investigate and treat. So that is why, and the last factor is an idiopathic. In spite of all these things, kuch samajh mein nahi aata. So these are the important factors that needs in a type 1 type of WHO classification. Type 2 WHO classification is a dysfunction. The first one was absolutely malfunction. Now it is a dysfunction, relatively better. So type 2 type of WHO is hypothalamic pituitary dysfunction. And here the criteria, this is the most common type. As I said, type 2 is most common. Almost 80 to 90% of the female fall in this particular group. Now here the imbalance GNH, high level of LH and fast FSH ratio less than 2. So in this particular group, you have a high level of LH and FSH ratio is more than 2. Normal estrogen and hyperestrogenemia is the common thing. So either you may have the hyperestrogenemia or the estrogen may be normal. Chronic and ovulation and oligomenorrhea are the important criteria to diagnose this particular disease. Now, what are the important causes? PCOS is the most important cause. Because, as Madam, she has explained to you in detail, that it has a number of variations, and the criteria for the diagnosis of the PCOS is based upon the presentation and investigation, and out of them the most important investigation is ultrasonography. And in PCOS, if you have an AMH level less than 1, nothing can be done. Because AMH, that is the ovary reserve, where the level is 1 nanogram per ml, that is what one should explain to the patient. Because what happens, the people who are in the private practice, the people who are in big private hospital, they are exploiting the people on the basis because they can earn first cycle 1 lakh, 2 lakh, second cycle little bit less, third cycle little bit less, and at the end they say, bhai, ye to parmeshwar ki meherbani ke bhai kuch nahi ho sakta, and that's all. They wash off their hands. So that needs to be understood. A case of PCOS with less than 1 AMH is, that needs to be explained because she will spend a lot of money. Childhood is one of the prime necessity for a woman. Childhood is a prestige of the woman, and the childhood that the child, she has to get the child, is one of the very essential requirement in the family. So for that, she or her husband is ready to do anything, ready to spend a lot of money. But that is the basis where the private practitioners, the larger institutions are exploiting them. Polycystic ovarian syndrome, PCOS, I will not talk much about it because Madam Mausami, she has spoken at length and in detail. So I will cut short on PCOS and only I will touch the important part. The presentation of the PCOS is, you can see the difference between the normal ovarian Graafier follicle growing and in PCOS, how bloated they are, and they can easily be diagnosed on ultrasonoscopy. So that is the basic difference. And of course, the hormonal imbalance, then the other investigations as she has taken up in detail, namely the presence of 2 out of the following 3 criteria, as she has explained very nicely, is enough to diagnose PCOS. The number 1, oligomenorrhea and anovulation, hyperandrogenism, and the clinical and biochemical changes of hormone occurring, and polycystic ovaries on the ultrasonography. So out of the 3, 2 criteria, if they are positive, it is a diagnostic of, and immediately after the diagnosis of the PCOS, we should go for AMH. This is a new concept. I was in New York before 6 months. As soon as the corona was over, there was a conference and top of line people have come and they say that if you are getting a case of PCOS based upon 2 criteria, you must immediately go for the AMH and try to find out. If AMH is more than 3, then you can continue with the investigation and try to treat this case until you go for IVF. It is based upon criteria-based treatment. You start from the one, your aim is you do not require IVF, but sometime you have to go to the IVF for the treatment of, because you go until that. But then if your AMH is less than 1, anything is not going to affect you. Even IVF with the latest of this technology is not going to help you, particularly even if you are introducing a sperm into this one, that is the ICSI. Even ICSI is not going to help you, because the taking up of the zygote is basically not taking place because of the low concentration of AMH. WHO class 3, it is again a very low in concentration, and here the criteria is hypogonadotrophic hormone hypogonadism, high level of FSH, normal LH, and low level of estrogen. The important causes are premature and age-related ovarian failure. Premature and age-related ovarian failure involves the age, resistant ovarian syndrome, and some of the genetic abnormalities like Turner syndrome. So these are the common. Again, it dwells in a very short range of 5 to 7%. So here, your investigation should be directed towards finding out what is happening. The diagnosis of ovulatory disorder, here the symptomatology is one of the important criteria, and that is cycle is regular, spasmodic dysmenorrhea may be present, and premenstrual tension syndrome is quite common. Mid-cycle pain is one of the important criteria, and then mid-cycle discharge and spotting are also seen. So these are the important criteria for the diagnosis of ovulation failure. Diagnosis of ovulation failure continue with the symptoms, that is, a diagnosis suggestive of ovulatory factors are irregular periods, headache, visual changes, galacturia, hyperprolactinemia, palpitation, heat and cold intolerance, and heat and cold intolerance is basically because of the thyroid dysfunction. The most important is hirsutism and hyperandrogenemia. So these are the important factor that needs to be considered and should be looked in while doing the clinical examination of the patient. The symptoms suggestive of ovulatory failure are excessive, this I have already taken, so we will not go into the details of this one, because then the examination suggestive of ovulatory factor suggests PCOS, and in this PCOS, we have to closely look at obesity, hirsutism, and breast examination gives you sometimes a galacturia. The signs of hypo or hyperthyroidism could be present, and investigation of Turner syndrome at last should be done, because that might prove to be one of the factors for this one. Underweight, that is hypothalamic factors, are responsible for that. Detection of ovulation, that what we do as a basic factor is the measurement of basal body temperature. Although there are so many other important methods which are in, but still the basal body temperature remains to be the gold standard, particularly in a non-tertiary institution, where the tertiary care is not, but in tertiary institution you have other factors to note where the ovulation is taking place. So ovulation, sudden thermal shift for first 10 days, anovulation, no thermal shift, and then the thermal shift occurs with the less than 10 days. So these are all some of the graphs which are showing the thermal changes occurring because of the ovulation. Hormonal assays, they play an important role, particularly the target progesterone level at day 21 of the cycle. And this is very important in terms, if the level is less than 10 nanogram per ml, ovulation has taken place. If the level is between 10 and 3, then there is a low period, and then it is less than 3, then ovulation has not taken place. So these 3 levels done at the level of 21st day as a target day could also give you an information on that. Serial LH in urine is another way, and to detect the LH surge at 36 hours before the ovulation. Now, doing LH in urine has become simplified because there are mono tests available and it can give you an approximate level of LH. So if they are done serially and it has been detected 36 hours before, then if you see the surge of LH, it is quite suggestive. Then serum prolactin, thyroid function test, serial vaginal smear, and endometrial biopsy. These are the remaining investigation for the detection of ovulation. Endometrial biopsy, of course, is not that easy. It has to be taken as a last resort. And then the most common cause of secondary infertility. Let us come to the secondary part. Now, secondary infertility is always dominated by some of the important factor, and the most important factor is pelvic inflammatory disease. Nowadays, we find a gonococcal infection and chlamydial infection extremely common in youngsters. And specifically, the young men, they go out and bring this particular disease and give it to their wives. So, gonococcal is easy to diagnose, but chlamydial infection is very difficult to diagnose because the criteria for the chlamydial infection is either you do the PCR or you do the culture. The culture of chlamydia is extremely difficult, while PCR of chlamydial, these are not available in every center. At our time, it used to be the tuberculosis. People had a lot of reserved mentality and they did not suffer mainly from gonococcal because availability is at par, and they did not suffer either from chlamydia. So tuberculosis is now the last factor that needs to be investigated. The block of the lumen of the fallopian tube, a fallopian tube blockage is one of the important thing, and here the tuberculosis is one of the most important reason, of course, apart from gonococcal infection and chlamydial infection. Nowadays, the tubal block is there. The peritubal adhesions, kinking of the tubes, at a previous pelvic peritonitis occurring to the woman, leading to ruptured appendix or other abdominal pathology. So these are the various important conditions of the secondary infertility that needs to be taken care of, and then they need to be treated appropriately. Surgery, that is previous pelvic operation done, previous ectopic pregnancy where a part of the tube was cut, and a cesarean section which has not been done properly or not taken care of, particularly in the primary health center where the facilities are not available, previous gynecological surgery, all these factors come under the surgery which are responsible for secondary infertility. Cornual fibroid, that is at the cornu, endometriosis, congenital hypoplasia of the uterus, aplasia of the uterus, and functional tubal spasm. They are the important factors for the secondary infertility. Tubal and peritoneal factors. Once it has gone to the fimbriated end, now the tube and other part. So tests for the tubal patency that we normally do, the gold standard was hysterosalpingography, saline infusion sonography, and lastly, the laparoscopy and hysteroscopy. All of them today still hold good, particularly when you deal with all these factors related to the tube and peritoneal conditions. The test for tubal patency remains the most important thing, and particularly the test done with the laparoscopy as a last part gives you a great bit of idea, and the laparoscopy has become extremely common these days in deciding about the patency of the tube. Other causes are uterine factors. The various factors in the uterus, particularly congenital aplasia, congenital hypoplasia, septate or bicarnuate uterus. These are the important congenital causes in the uterus that is affecting the fertility. Uterine surgery, and then as a result of surgery, the fibrosis and some amount of adhesion has occurred, also prevents it. Endometritis and Asherman syndrome, endometrial polyp or endometrium fibroid, prolapse and retroverted uterus, and refractory endometrium. So these are the important causes. that needs to be looked for the secondary infertility. And refractory endometrium, it has multiple definitions, and this refractory endometrium has been put as a last resort, as a last diagnostic resort. Coming down the lane, cervical factors. The cervical factors are congenital stenosis of the cervix, trauma to the cervix, conization or cauterization of the cervix, obstetric trauma occurring during the episiotomy or any other minor surgical process, then chronic cervicitis, hostile cervix mucus. Now, hostile cervical mucus is one of the immunological factor where you find an anti-sperm antibodies in the cervical factor, and that causes a complete cessation of the motility of the sperm as soon as it is discharged in the posterior cervix. Cervical fibroid can also distract your attention and could be the cause. And immunological cause, as I told you, anti-sperm antibody is to be kept as a last. But nowadays, we do find a large number of cases in our laboratories coming with a anti-sperm antibodies positive, and these are the important causes. Now, investigations in the cervical factor remains the quality of cervical mucus and ovulation. Post-coital test nowadays nobody is doing, but it is to be done in a specific case. Sperm penetration test is another test where that needs to be understood, but then these are the last ranking test where all other tests above are negative. Culture and sensitivity of the seminal fluid is very important, particularly for the infected cases, particularly for the gonococcal and streptococcal pneumonia. These are the two important organisms where the seminal fluid can cause the problem. The diagnosis of immunological factor remains, this is the last and the least to think about. Immunological factor today, we are thinking as the last factor. Then the various types of anti-sperm antibodies can be tested with agglutination, with an agglutination test, with an immobilization test, and the immunofluorescent test and immunobead testing. So these are the important immunological factor testing. One of the most important is immunobead testing, which is highly sensitive, which gives you information on anti-sperm antibody. And that's what is very important thing to note about. Unexplained infertility. This is doing after all the investigations and everything is normal. Male factor is taken into consideration. Female factor has been taken into consideration, and all of them have apparently found to be correct. Then this case can be labeled as unexplained infertility. And consolation for unexplained infertility is जब भगवान को देना है तो देता है, और जब नहीं देना तो वो कुछ भी कर लो नहीं देता. It falls in this group, and this particular group is less than 5% of the total cases of infertility. There are people who believe, and I'm one of them, that this particular factor plays an important role. फिर आप उसके बाद में क्या करना, तो फिर लोग मंदिर जाते हैं, दरगाह जाते हैं, चढ़ावे चढ़ाते हैं, but then it is all useless. कुछ भी नहीं होता. बाबा जी के पास में जाते हैं जो बड़े बड़े भक्त और गुरुजन होते हैं, and they are exploiting the वो बिचारी फीमेल को वो exploit करते हैं, but then it is all useless. So unexplained infertility should be left to the God. If God wills, there are cases of unexplained infertility for 25 years, and the women conceived in 26th year of the marriage. It's a miracle. But then it happens. It is not unseen. It is a seen cases like that. अब उसको आप क्या नाम देंगे? What you will call it? It's a wish of great Lord of the universe. That is what. Thank you very much for patient listening. And I will be great to answer your question at the end when the question answer session begins. Thank you very much.
Thank you so much, Dr. Iqbal. Any questions from the audience? I think it was a lucid and wonderful talk by Dr. Iqbal. He has covered almost everything as far as infertility is concerned. And since I am getting this opportunity, I would like to throw light on some of the points which are also important in a day-to-day practice. One point which rightly Sir has said, that infertility definition. The trends are changing now. With the age of 35 and above, the treatment or investigation should be started within 6 months of if the patient is not conceiving. That is the age factor, because the patients are marrying late or girls are marrying late. Another point which Moushmi has very rightly said is about PCOS. And in PCOS, suppose the patient comes to you within 1 month of marriage, because she is a known case of PCO, overt PCO, with very high LH, obesity, hirsutism, and she knows that she has a problem. She knows that she is going to have difficulty in conception. You can straight away start investigation in the first month of marriage as well, because she knows there is a problem and you also know that there is a problem. So this is about the duration of infertility. Then, as far as premature ovarian failure is concerned, we now call it premature ovarian insufficiency and not failure, because there is a difference between failure and insufficiency. Failure is not a good term to use or to apply. Therefore, we call it insufficiency. And it is becoming so common these days that it is actually eye-opener for all of us, that we all as a clinicians should do this kind of social work in the society. We should tell patients that they must marry early, because there is one study which has appeared in Fertility and Sterility in 2014, which says that the ovarian reserve of Indian women is 6 years ahead of Spanish women. That means the ovarian reserve of a 32-year-old Indian woman is equal to 38-year-old Spanish woman. So it's an eye-opener, because our ovarian reserve is falling drastically after the age of 32 years. And that is the reason why we must tell them that please marry early and please have kids as early as possible. Something which we all should also, because there are many residents here, and they also should keep this in mind, that they must marry early, because the ovarian reserve in Indians and Southeast Asians falls dramatically. Then another factor is rising male infertility. And I think Sir has rightly said, when we were during our GMC days, 91, 92, we were taught that the incidence of male infertility is 30%. And now it has gone up to 52%. So it is more than the female incidence. So the male factor is rising tremendously. And female factor ho ya na ho, male factor zarur rehta hai. And that is the reason why we must also think about this male factor. As far as unexplained infertility is concerned, explaining the unexplained is something which is very difficult. And as Sir has rightly said, if you don't know what is the cause, we call it as unexplained. But actually labeling a patient as unexplained infertility is actually a failure on our part. I will give you a very small example. Suppose you do semen analysis. Semen analysis will give you an idea about the sperm count, motility and everything. But there is something called as sperm function test. There is something called as DNA fragmentation test, which is not done in semen analysis. And suppose you do DNA fragmentation, and if the DNA fragmentation is 90%, then this man is not going to father a child. That is for sure. So you have to go into the depth of unexplained infertility. Exactly. So these are the factors which are important. Similarly, we always say that IVF is not only therapeutic, it is a diagnostic modality. Because there are so many things which are happening inside the body which you don't know. A oocyte quality. Suppose if you see everything is normal, the patient is ovulating, endometrium is good, but she is not conceiving. You do her IVF and see the oocyte quality. The oocyte are poor quality oocytes. They are so bad that this is the patient who is not going to conceive because of the poor quality of oocytes. Something which we do not know unless you do IVF. So these are the small things which really matter as far as infertility is concerned. I'll end my special comments here, but with a very important fact that AMH is now becoming the most important investigation as far as ovarian reserve testing is concerned. Suppose you look into the 2018 guidelines of PCO, it is said that AMH is an experimental investigation, still not used very commonly because of the the problem with the lab standardization and the cost factor. But the very next year, एक साल बाद 2019 में जो एशरे के गाइडलाइंस आई है उसमें उन्होंने बोला है कि AMH and AFC, antral follicle count, are the two investigation which alone can give you idea about the ovarian reserve of a woman. So they have suddenly given a special status to AMH, that AMH alone can give you idea about ovarian. So AMH is becoming so important. Why? Because whenever there is PCO, the patient has got high AMH. Whenever there is a premature ovarian insufficiency, there is a low AMH. But what about the normogonadotrophic normogonadism patient? Or what about the patient with hypogonadotrophic hypogonadism? These are the patients where you can decide whether the patient is going to respond to your ovulation induction or not, depending on the AMH reports. So AMH is so important nowadays that it is the sole investigation which gives you idea about so many things. So with this, thank you very much. Once again, thanks Vaikar madam, Kamal madam and Deshmukh sir for giving me this wonderful opportunity. And Dr. Iqbal sir, it was a wonderful talk. Thank you so much. Thank you.
Thank you, sir, for very valuable guidance on this topic.